of the most experienced person will tell us about new frontiers, Debdulal.
Sir, thank you for this opportunity, sir. And today, probably we don't need to tell each other that anti-VEGFs are the preferred first line of treatment as far as center involving diabetic macular edema goes. But let's look at this case. So this is a lady, 56-year-old, lady, and she is fairly controlled with like her diabetes. And this is her list of injections: 20 ranibizumabs, 3 bevacizumabs, 2 aflibercepts. And because these were not working, so I jumped the gun and did a IVTA. And lo and behold, we had the raised IOP, and thankfully, God saved me, and it was controllable. But what is the background story? This patient has been with us for since 2014 and up to 2019. She has had 62 visits. This is a patient who's actually very compliant, and she has had 28 injection visits. So just imagine the predicament of the patient. So is this unusual? Not really, because if you look at the studies published with Boreal study, even with 7.6 mean injections, there was a treatment failure of 24%. And if you look across anti-VEGFs, then the rates are even higher, up to 40% non-response. And this stems from the fact that many of the patients are partial, poor, or non-responders to anti-VEGF therapy. So we have unmet needs, as has been amplified. We need better drugs, more durable drugs, and difficult to treat phenotypes need drugs that are different. So one very important thing is we mostly go PRN in our country, believe it or not, or agree it or not. And a lot of these patients get 3 injections at the most, maybe even less. And Luminous study says 50% maybe get 4 or less injections, 60% up to 5 injections. So that's not going to do good if you are looking at some improvement of vision. It might maintain vision. So you need 5 to 7 injections of ranibizumab if you are to treat these patients. India is a special case. As in the developing world, non-affordability is a big factor. Multiple number of injections, multiple times coming to the hospital is very difficult. And as I mentioned, PRN regimen is something that we vouch for. So we need new frontiers in the treatment of DME. And one of the new things that have come up, just like sir mentioned, was brolucizumab. It's a small molecule. You can pump in more drug, as also faricimab and PDS with ranibizumab. Now these two are not yet available in the country and probably be available soon. But going back to our index patient, what happened post this raised IOP? We offered her brolucizumab. It was off-label at that point in time, and this is how the patient behaved over the next 3 months with just one injection. There was improvement in the anatomical characteristics. There was some degenerative looking cysts. We held back till 3 months, and this is what happened at 4 months. So there was intraretinal fluid distinctly coming back, and this is when we injected her with the next injection. The story since then, long story short, 8 injections of brolucizumab over 2 years from time of shifting over to brolucizumab. So this could be something that could dry up the retina better. And like sir mentioned, all fluid may be something that's not really good for the retina. So is it justifiable? Well, the studies do say it's justifiable because brolucizumab patients treated with brolucizumab have lesser IRF and SRF, as per studies. And visual acuity wise, it is pretty much similar to aflibercept, non-inferior to aflibercept. So also the central subfield thickness, but fluid drying is something that's better with probably brolucizumab. Sir brought up the topic of adverse events, and with Kestrel and Kite, it's even Stevens as far as brolucizumab and aflibercept is concerned. 1% versus 2% for brolucizumab versus aflibercept, and this is 2% versus 1.7%. So pretty much similar. And I'd like to share a couple of our publications. So this is part of the series of that 3 cases. So this is a patient who received 11 ranibizumab injections, a very strong family history of diabetic, father going blind, 37-year-old teacher, and I didn't have the guts to inject steroids with him, offered him aflibercept. But interestingly, this is a patient who actually is with the West Bengal government schools and has the patient support scheme from the government. So 1 month post brolucizumab, this is what happened. There was this reduction in the fluid, And this is 3 months post brolucizumab for further reduction, and what looked like a degenerative cyst reduced further. Some improvement of vision as far as the patient was concerned. There's this FAZ distortion, and this is 4 months on. The retina still looks dry. So these 3 cases showed a similar pattern of the activity of the drug lasting for up to 16 weeks. And basically, if you look at the back end story, 8 injections in the first patients, 9 in the second patient, and 8 injections in the third patient over a period of 2 years. So you have a drug that's probably more durable than what we have as of now. The other publication that we had actually was interesting. This is 13 patients who had a mean of 15 injections of different anti-VEGFs and steroids, and this is something I thought was important. If you look here at 4 weeks, there's a significant improvement as far as the visual acuity is concerned, and this is something that lasts out till 12 weeks, and beyond that it starts to wane off, as also the central subfield thickness. Up to 12 weeks, it is statistically significant, and then it wanes off. So you have to find a sweet spot maybe somewhere here to re-inject these patients. And we didn't have any inflammation in these patients, and up to 6 months, the mean number of injections required was just over 2. So basically, brolucizumab is effective in recalcitrant DME. I'd like to share a couple of cases to end in naive situations. This is a non-center involving DME that we did laser in both the eyes, and post 2 months of laser, this is how the retina looked like. Again, a West Bengal health scheme patient, and so we injected brolucizumab with oral statins, and this is how the retina looked after 3 months. Some improvement in vision, and actually there seems to be some reversal of the drill. I'm not sure about that, but there seems to be a reversal. Now let's look at this patient. This is the last one. Retina looks okay-ish as far as the fundus is concerned. Vision is not too great, 618 versus 624. And this is how the OCT pictures, looked at presentation. So we offered him a bouquet of, all agents. And again, this was a West Bengal health scheme patient. And this is at 3 months. The retina looks better, and the OCT, of course, looks better. And the retina is still dry at 3 months. So brolucizumab is effective in treatment of DME, it seems, and there may be, it's something that's effective in reducing the treatment burden because you need lesser number of drugs, and tackling DME, as sir mentioned, more aggressively with a more potent agent could be beneficial. So that's all. And I would like to take this opportunity to welcome you all to the next AIOC at Kolkata.
Debdulal, excellent talk as usual. Really enjoy your talks. But one thing I did not like was maybe it is effective for reducing treatment burden. What is the shyness?
Sorry, sir.
Why? No, what you last slide? Your slide said it may be. Can you put the last slide?
Yes, sir.
I may ready. You see, first line is perfectly okay. Brolucizumab is effective. No doubt about that. Why are you saying may be effective?
Sir,
you see, two things, because all through your talk, you said it is better drying effect.
Sir.
Secondly, you also emphasized 12-week interval.
Sir.
Then why are you shy to say it may be?
Sir,
why are you shy?
Yes, sir. Specifically because I have a published evidence of only 15 cases. But
so if I was you, I would be bold enough to say that here is an agent which can reduce your treatment burden.
Sir, thank you, sir.
Thank you for very nice illustrations.
Thank you, sir.
So, thank you. Excellent messages conveyed. That is the beauty of Debdulal.